This meeting is being recorded.
Hello everyone, this is Mackenna. I'm going to start my presentation now on the causal mechanisms of pseudocyesis. Pseudocyesis is a delusional disorder which can occur in women who either desperately want to be pregnant or deeply dread pregnancy. They will stop menstruating, lactate, have morning sickness, which are all the signs of a true pregnancy. However, they do not have an infant inside them. It's important to understand that pseudocyesis is different than malingering, in which a non-pregnant woman consciously claims that she is pregnant to gain certain advantages. Pseudocyesis occurs when a woman truly does believe that she is pregnant. The Western medical literature describes pseudocyesis as a very uncommon condition, with the prevalence in contemporary gynecological practices within the U.S. as having only 1 to 6 cases per 22,000 births. However, in the continent of Africa, 1 out of 160 patients present with this delusion. Cultural variations in their effect seem to hold an important antecedent to this condition because in developing countries where there is a strong familial and cultural pressure on women to be fertile, this delusion develops. Psychological antecedents seem to include ambivalence about pregnancy, relationship issues, and loss. And very frequently, this delusion occurs when a married couple is infertile and lives in a pronatalist society, such as one where the cultural pressure on women is so high to be fertile. The effects of the hypothalamus are important to discuss because the hypothalamus releases hormones such as prolactin, which are an important maternal hormone, and the hypothalamus is significant to emotional regulation and output. Ramachandran explains that the hypothalamus can go awry, producing hormonal shifts that mimic pregnancy, and this helps us understand the mind-body interaction and its prevalence in this disorder. Psychological effects are important as well because psychological factors stem from primitive gynecological challenges such as infertility, recurrent abortions, and remarriage, which can all hold a psychological variation within women. Causal factors that are seen to have the most significance within psychological effects would include an intense desire, wish, or fear of pregnancy, which can result in pseudocyesis through complex neuroendocrine mechanisms. Secondly, misperception or misinterpretation of sensory stimuli can be indicative of pregnancy for some women, and this can be seen in states of abdominal distension or pressure on the pelvic structures. Depression is an important causal mechanism because the depression of being childless in a child-obsessed culture can stem from a longing for a child, and this can reduce levels of dopamine and norepinephrine, which are the joy transmitters in the brain. Due to this reduction, the production of both the follicle-stimulating hormones, which cause ovulation, and a substance called prolactin inhibition factors can be affected. Low levels of these hormones would lead to a cessation of ovulation and menstruation and an elevation of the level of prolactin. Psychosis is another important causal mechanism because pseudocyesis can be tied to hyperprolactinemia, which is an elevated prolactin level. Hyperprolactinemia can result from psychological stress, specifically that of a psychotic episode. Although prolactin levels can be raised by many organic conditions, they can also be raised by drugs such as estrogens, antidepressants, and opiates. In women suffering from psychosis, delusional pregnancy is not uncommon because the advent of antipsychotic medications, which by virtue inhibit dopamine secretion, raise prolactin levels to produce specific experiences of pregnancy. Pseudocyesis is also an occurrence in men, and Ramachandran wonders if the emotional empathy felt by the male partners or the hormones released by their pregnant partners release prolactin, which we have seen as a pregnancy hormone. Male tamarin levels develop at an elevated prolactin level when in close proximity to nursing mothers, and this can encourage paternal or filial affection. It is commonly seen in men who empathize with their pregnant partners, reducing the so-called sympathetic pregnancy or producing the so-called sympathetic pregnancy or COVID syndrome. In conclusion, the most notorious influences of this disorder seem to exist within developing countries because they do not have as much access to Western medicine that can infer the pervasion of true pregnancy. Additionally, in some developing countries, the stress surrounding pregnancy caused by social pressure and cultural practices seem to influence the development of this disorder. Depression and psychosis seem to lead to a feedback loop where the mind-body influences can be observed. And the fact that men too can experience pseudocyesis points to the immense influence hormonal outputs can have on the mind-body interaction. Thank you so much for listening. Here are my references.